Hey, everybody, welcome to another episode of the OIG Roundtable. We got a great topic to talk about today, durable medical equipment. I smile because I don't know if it's a great topic or just a topic. I guess we'll know in a minute. And as always, joined by my two partners in crime, Wade McFall, retired assistant special agent in charge from the LA field office of the OIG and a manager on our investigative team, and Matt Kachansky, retired special agent in charge from the OIG and the retired Northeast UPIC director. We were doing introductions yesterday on a meeting that we were in, Wade, and I had to acknowledge the fact that I've known Matt for almost 30 years. I don't know if that makes
Maybe
Matt very
it's getting close, yeah.
getting very close. 1997, new
Yep.
agent training, and new employee orientation. Spring of 1997. Yeah, I don't know if that made me feel old or it made you feel older. Probably a combination of
I
the
can't
two.
feel older.
That is true. So today we want to talk about some of the issues that are out there that are prevalent issues with DME investigations in the SIU space. You know, we see there's a constant influx of press releases that are out there regarding DME cases that are still out there. You know, obviously during COVID and in the post-COVID world, we've seen a lot of that relative to the fraud, waste, and abuse issues that exist with telefraud schemes, right? The genetic testing, the pharmacy stuff is still out there. A lot of the DME stuff out there, right? We still talk a lot about the $2 billion catheter case that went on, and the shell companies and all of that. And we're still seeing a lot of these DME cases come in. And so, you know, one thing that's recently come up is I'm working on a very large SIU project right now with one of our payor clients, where they've got this dispute going on that's been going on for many years, involving overpayments and capped payments in Medicaid. Now, the Medicare rule on cap payments is that you can rent the item for, there's a list of things that have this cap payment versus purchase. The big one, wheelchairs are a huge one, mattresses are a huge one, where there's a rent to, and then you own it. In the Medicare space, it's typically 13 months. And once you've gotten paid after 13 months, you own it. And then Medicare will pay for maintenance and for repair. Some states have different rules. I've seen some states have, there's one state in particular where they have a rule that's as low as 10 months. And what happens is there's a capitation, which means that you're billing for this item over a 10-month period. And then after 10 months, it's owned. And there's a fee schedule and what have you. And there's baked into a lot of the state regulations, monthly amounts or caps on the percentage for that item that's out there, or that product that's out there. And so the biggest piece of this is that some of these cases may involve what we would kind of colloquially call strict liability, which means the rule is you can bill it for 10 months. This is the amount. After 10 months, they own it, and that's it. And if you bill over it, you have to have the invoices. It's overcharging, and there's not a lot of medical record reviews that need to be done because the policy says you can do this, you can't do that. And it's a strict liability issue, meaning that your billings are going to kind of drive where that all goes. But what winds up happening is that sometimes these cases result in disputes, and these cases result in appeals, and these cases result in long-standing discussions. The project I'm working on right now, there have been disputes going on for a number of years. The overpayment calculation spans even a longer period of time. And so we're sitting here now in 2025, and, you know, medical records may have been missing. They may not exist anymore. So you have to pre-plan some of these things, and you have to think a little bit ahead about what you need, what you don't need. So Wade, number one is, right, when you're vetting the case, you're deciding you're going to work on the case and all of that, you have to do part of this investigative planning, and we know that that's fluid, but sometimes investigative planning is going to require you to think a little bit ahead about what you may need in the future, and know that, you know, cases don't always go as smoothly as they go, right? So what are some of the things you have to think about from that long-term investigative planning, and making sure that things that you need to tomorrow exist today, right? You may not need them today, you may need them tomorrow. And you got to think about all of these things in that operational planning, particularly with something like DME, where getting records may require multiple steps, not just
Yeah.
from the supplier.
Yeah, and I think you hit the key point there is that when you're making your investigative plan, it has to be fluid, because as the investigation progresses, it's going to take different you know, angles, and you're going to have to adjust to what it is that you're finding out throughout the investigation. As far as not ordering record, for example, medical record request up front, first of all, there's a couple elements in that where you're probably ordering them from the DME company initially. Even if you don't think you need them, you probably should, because you may need to look at medical necessity or different issues before that. You're going to, it could be 2-3 years down the road, maybe 4 or 5 years down the road, and you're going to be sitting there thinking, wow, I really should have requested records back in the day. Primarily because you would request them from the DME supplier. They're required to have the medical records on hand, but they may have to get them from the physician's office, the referring physician. And I know in LA that it's not like these clinics and physicians stay in one place forever. They tend to be kind of mobile. So in 5 years, not only will the DME company not probably be able to get the records, but you wouldn't be able to reach out, because that clinic, and there's some that are probably have been there for 10-15 years, but a lot of them, they're there for a few years, they move on, they change their address, whatnot. So it would be really difficult to even try and get them years down the road. And as you said, if it's whether the investigation takes 3, 4, 5 years, which is possible, you could think you're done with the investigation, and then it comes back with some kind of an appeal. Maybe even if it goes to trial or something like that, there's always appellate issues. So it's really important to have that up front. Even if you don't think you're going to need it, think of all the possible ways you may need the records, and really think ahead and make that request early, because you're really not going to be able to do it, a couple of years down the road.
Right. Well, and part of it is also that the DME supplier, they may not have to have the records on hand, but they certainly have to have access to the records, because the medical necessity piece, and let's take in the DME space, when we're talking about wheelchairs, for example, is always a great example. The ordering provider may say power wheelchair and just leave it at that. Well, the problem is that the doctor's not going to the member's house and taking measurements, right? Because the wheelchair has to be able to be used in the house, outside of the house, right? It's not a jazzy scooter. You're not using it just when you go to Walmart or Target. It's supposed to be part of the activities of daily living, or ADL. And so the supplier has to have certain documentation to be able to show, hey, the doorway is wide enough, or it's not wide enough, or whatever it may be. But in some instances, you've got like a situation maybe with a mattress, a pressure mattress, or some other piece of DME where the resident of a nursing home is getting it. The member lives in a nursing home. And so those records are going to be at a nursing home. And depending upon state law, the requirement for maintenance of medical records could be 6 or 7 years from the last visit. So you could have someone who has been a resident of a nursing home for many, many years, or the ordering doctor has been treating this patient for many, many years, if it's not in a nursing home. And you might have a situation where the visit could be 10 years old, it could be 8 years old. But more importantly is that if you're in an issue where there's ongoing litigation, unless there's a litigation in which there's a litigation hold put on those records may not be there, right? So thinking in that operational planning piece, you may get records and right way, you may not look at them, but it's better to have them and preserve them as evidence, right? So, that's an important, just think about like in terms of search warrants. How many times have you gone out and done search warrants where you looked at only some of the records, not all of the records, but you wanted them to be able to preserve them, right? That's a little bit of that metric. So think in terms of, so operationally, I think getting the records, there's no real additional cost, but you also have to think in terms operationally of when you're starting this investigation, what are some of the things you might need in the future? So let's talk for a minute. What would be some of the things that you would be looking at from a, not documentation perspective, but helping to kind of figure out operationally what might you need in the future from a documents perspective. What are some of the things you're considering as like, your guidance or what have you, for lack of a better term, guidance to thinking about what might I need in the future?
I think you probably have to pull from all the other similar cases that you've worked. If you work different DME cases, maybe it's the same type of DME, maybe it's, alternating pressure pads, maybe it's wheelchairs, maybe it's different orthotic support devices, that type of thing. But even if you're not, even if your current investigative plan doesn't really necessarily include the request of certain documents, you should take your knowledge that you've gained from these other investigations and think, maybe down right now, I'm not looking at whatever it is, medical necessity or different elements that you'd be looking at. Maybe I'm not looking at it now, but I know in this other DME case that I've worked down the road, this medical record came in really in handy for, whatever reason. And you have to kind of apply those kind of same principles, even if that's not the focus of your current investigation.
Right.
Hopefully you've learned from, going down that road, and maybe it's making mistakes you made before, but you have like a base of knowledge on what you might potentially need those records for. So you really need to be thinking not only just a couple of months down the road, but years down the road, what
Right.
may be required to prove the case.
Yeah, it's a great point, and that really does lend itself also to kind of the collateral discussion that we have frequently, which is speak to the people within your payment integrity team or your program integrity team, right? Your auditors, your coders, people that are in the policy department to help you understand what might I need. So Matt, this gets right to the next piece of this, which is that what we're seeing in some cases is that payers do not have edits in place that are aligned with policy, whether it be a policy from the payer, whether it be state policy, right? So in the Medicaid space, there could be a state in this particular project, there's actually a state policy that says you're going to get paid for 10 months and then you don't get paid anymore. And you're going to get paid invoice plus a percentage above invoice, right? So in an investigation, you'd have to get the invoices because there's no way to know. Eric Rubenstein, DME provider, you as the payer, you have no idea how much I paid for this item. And that's where part of that investigation. But a misalignment of policies is going to have the potential to be a challenge. It doesn't mean that the fraud, waste, or abuse didn't happen. It's still fraud, waste, and abuse is still fraud, waste, and abuse. If you don't have an edit in place, you're really working pay and chase versus stop and verify, right? When get away from the phrase prepay, stop and verify. But you're really, when you have this misalignment, you're having to do, it's a lot more work, right? You're not saving money, you're fighting it. It's costing money to track it down. And then from a policy perspective, you could have a policy, but if no one is bothering to ensure that the edits are properly in place, this is exactly one of those instances where payment integrity is really program integrity between payment integrity, SIU, policy, all of that.
Right. And this is what we've been preaching, since episode 1, is that program integrity and SIU, it's a continuum. There has to be coordination, collaboration, communication, the 3 C's, amongst all of the groups that have anything to do with program integrity, whether that's enrollment, claims administration, whatever it may be, because what we find at the back end many times is a result of things that are missing at the front end, whether that be a good enrollment vetting system where they're letting in bad providers that might be excluded or whatever it might be, to missing these edits. And our experience at Advise, my experience at the UPIC, was many times these edits are not in place because it costs money for the claims processing to slow down that process to put these edits in place, and that costs them money. So I don't know if they're making a cost benefit analysis and saying, there's a policy in place, but it would cost us more to enforce it than to just let it go and let it be caught at the back end. I don't know what kind of those decisions are being made, but it does happen. It happens with DME. It happens with simple things like E&Ms and the urine testing on the same day. 69 cents, $2, whatever that urine test is, it's included in the E&M. There should be an edit in place that stops those. I've yet to find one. Even though it's an NCCI edit that CMS has created, I've never seen one in place that's been effective. So part of the role of the SIU is to identify those weaknesses and work with program integrity units, program integrity people, compliance, and get them put in place, and then then check the edit effectiveness of it, to work with them to have yearly audits. How much was saved based on this edit in place versus how much did it cost you to put that edit in place, to show them that in the long run, it does benefit the plan to put these edits in place. But I will go back a little bit on what Wade was talking about, which I thought was interesting in terms of investigative planning. One of the things we always did was, pull a member history. Prior to getting the DME, did they have diagnoses and services that would have related to the reason for the DME? Get those medical records as well. They might not be from the referring physician, especially if it's an institutional setting where the referring physician may be the medical director of the institution. Maybe their regular physician is finding issues that in the past that they needed these things. Did the patient die? Even within the 10 months, even if there is an edit in place, is there still something there because the patient died or no longer needed the mattress for whatever reason, that you're not going to know unless you get the member history and any of the medical records associated with that history. So you're not just looking at the DME company, the institution, the referring physician. There may be other records that you need as well.
Right. And that becomes part of the discussion is there anything to show? Can we cross-reference back? Did this patient die during that ensuing 10 months? If the claim, the question that I posed was, can we confirm that the supplier billed for the contiguous 10 months? And the answer is yes. And then my follow-up question is, can we confirm that the member was A, still alive, B, if they were still alive, still in that nursing home, and C, still had a need for that pressure mattress? The only way you're going to know if they still had a need for that pressure mattress is going to be the medical records. And then the question of did they die or not, you're going to have to do some cross-checking, because if they are still are they still on the rolls? Do we have proof that they're alive? Like what's so those medical records have some collateral uses, uses to them. And I think, we get caught up sometimes in these strict liability cases when at least when I see them, because it's really just it's a policy-based edit. So there is no medical necessity argument, which when I spoke to the investigator, the reason that the investigator did not request medical records was because they didn't look at medical necessity. And I said, but that's only one reason that you request medical records. The medical necessity piece is only one part of it. And that's what I said. Because my initial question was, the policy says that in order for this member to get this item, they have to have this as documented medical condition, or one of these three, whatever the numbers were. And I said, have you confirmed that the resident had this condition? We didn't get medical records. Okay, but is there a diagnosis in their history that supports that they had this? So there's a whole bunch of collateral things that, that can be done. The problem is that if there isn't an edit in place, you're now figuring all this out. Whereas if there was an edit, and you can have an edit, you can have an edit for time, right? Month. You can have an edit for cost. You can also have an edit for mismatch diagnosis, right? We see mismatch diagnosis edits all the time. Obviously, E&Ms are the most challenging because almost every diagnosis is going to fall in. But if you have a particular item that you're getting, it's not like there's going to be an infinite number of diagnoses. There's always going to be within that policy those diagnoses. So, the edit has to have a few things to make it work in order to be appropriate. And I think that's where you have to have this intersection. And Matt, it gets to the whole premise of communicating between the SIU payment integrity creates a robust program integrity. And that's where we get to this whole premise of having these conversations. And Wade, we talk about this all the time. You can't, as an SIU investigator, you can't work in a vacuum. I know that, we have made some tectonic shifts here at Advise. I love to call the auditors we have here auditors, because they're really doing an investigative audit, right? And I know our auditors speak to our investigators frequently. Sometimes we have to tell them, stop going down the rabbit hole, because you're opening up a can of worms. But Wade, final word on this is you can't live in a vacuum. You can't know all the policies. The auditors know the policies way better than we will as investigators. The auditors understand NCCI, MUE. They understand that communication becomes a key piece internally in shaping what your operational investigative planning is going to be.
Yeah, and we've talked about this on podcasts many times, and it's, I think you can boil it down to, it's not really, you don't have to know everything. It's not what you know, it's who you know that may know what you're looking for. So it's having that quote unquote Rolodex with the right people in it. And that might just be, it might be a Rolodex of people from all over. It might be the auditor that works beside you within the same SIU. So it's really boils down to that. Like you can't know everything. And that's the other thing, is a lot of these SIUs, you're looking at everything from behavioral health to, very vast categories, I guess. And even within the auditors, the CPCs, we have some that specialize in behavioral health, some that specialize in different things. So even within the number of members within the SIU, you might have to go to different people, different points of contact for different subject matter, because they all have their expertise beyond what you as the investigator has. So they generally have a different focus and
Right.
history. But even within that group, you might have somebody who specializes in a certain area. So having the knowledge of their background and knowing who to ask what questions is, frankly, more important than trying to learn it all, because you just can't. There's too much variation in it.
Right. And the takeaway is, we could all sit and read a policy ourselves, and that's all good and well. But our auditors understand what documentation would look like to support that, right? So when you're shaping that, it's making sure that you're getting that the right documentation at the right time. The worst thing that can happen is it's a year or two down the road in the SIU space. I don't know why we would still be there if it's something that, but it does happen. This is a classic example of it. But, when we do run into a situation where it's a year or two down the road, some of the things that would have, could have, and should have helped you to further your case one way or another, because not all cases are overpayments, right? Sometimes it's just a resolution of some sort. Okay, they're good to go. But you don't want to be behind the 8 ball a year down the road and realize, man, had I just requested these records, I could have gotten this resolved 6 months ago, 8 months ago, or in the worst case scenario where you're a year or two down the road and you need something and it just doesn't exist anymore because the provider's not required to maintain that. The claim has been paid. It's a final adjudication from the state regulatory perspective, medical board perspective. They have met the requirements for maintaining those records. It's not their fault, right? At some point, the record's not existing. It's not their problem. It's because we didn't think ahead enough on our feet on these. So think about this. DME is a challenge. They can be challenging cases, particularly when the product has been provided, and you're playing the chase game. You got to have a little bit more forethought, because time sometimes can be of the essence, particularly because you have to track down documents sometimes from 2 and 3 sources. And the data analytics piece, you have to really cross-reference a lot of things, other common beneficiaries, payment models, where is the resident or the member if they're in a nursing home. So a lot of these become factors that really have to be vetted while you're doing that. So for those of you who work in these DME cases, they really are a challenge. Keep up with it. Stay vigilant. Keep up with reading the press releases to see what's happening. Keep up with your policies on DME. Speak to auditors that are very conversant with DME. DME is really niche. Getting those certificates of medical necessity and things of that sort, particularly as you get into some of the more niche DME, wheelchairs, custom foot orthotics for diabetics, huge area fraud. People should not be getting a Dr. Scholl's rubber gel insert, with their Skechers slip-ons and treating that as a custom orthotic. So, those are things you have to keep in mind. So keep up with it. Reach out to us with questions. We're happy to engage you and help you work through some of these issues and these nuances, and keep up with reading the press releases and our blogs. We're talking about this a lot in the blog. So as always, we appreciate everybody for participating. And Wade, Matt, good seeing you guys as always. Good insight. And keep up with our newsletter Fridays right in your inbox, advisehealth.com. Get it every Friday, along with all of the links to our OIG podcasts. You'll get them again on Spotify, and you can subscribe right through our YouTube channel. So until next time, we'll see everybody on the next OIG Roundtable. Thanks for participating and tuning in.
Thank you.
Thank you all.